Hi, I'm Dr. Timothy Swartz. I'm a rheumatologist here at the Arthritis Center of Michiana Spine, located in Kalamazoo, Michigan. One of the big distinctions we have to make when we see people with arthritis, is it degenerative or is it inflammatory? And the two most common diseases that would represent that would be osteoarthritis for degenerative type diseases and rheumatoid arthritis for inflammatory diseases. A lot of people will think they have rheumatoid arthritis when really it's more the degenerative type that they have. There's certain characteristics of each that we look at to determine which it is, and it is our big division point when we're making up a differential diagnosis as to whether it's degenerative or inflammatory. With degenerative arthritis, there's a lot of stiffness. The stiffness seems to be limited, however, in that it'll be for 10 or 15 minutes in the morning. It'll be for 5 or 10 minutes if you've been immobile. So when you get up in the morning and you're stiff and you're sore, but by the time you walk to the bathroom and get moving around, you're feeling better, that's more consistent with the degenerative arthritis. For rheumatoid or another inflammatory arthritis, the stiffness seems to be more pronounced in that it may take 1 or 2 hours for it to go away in the morning. And so you'll be sitting around and you'll be moving around, but it'll be after breakfast or even later than that before you start feeling like your joints are moving better. So that would be a clue that it's inflammatory. The other thing we look at is the joints themselves. There can be swelling with both kinds, but with degenerative arthritis, the swelling is what I call hard, and that is because it's bony proliferation. With degenerative arthritis, you tend to make extra bone. With inflammatory arthritis, you make less bone. So the knuckles you'll see, if you feel your knuckles with degenerative arthritis, they'll be very firm and you'll say, oh, it just feels like bone. If you have an inflammatory arthritis like rheumatoid arthritis, it'll be, I call it a soft swelling. So it'll be a little mushy, almost like you're pushing on a sponge or something like that. And it's also more likely to be tender if it's an inflammatory arthritis. So that's when we need to see people to know whether that's the case. The other thing we look at is how tender the joints are. Now, the joints can be tender with both types, but with inflammatory arthritis, such as rheumatoid disease, they tend to be much more tender, so it takes less pressure to make one hurt. Also, with inflammatory or rheumatoid arthritis, you're much more likely to see some redness over the joints. Occasionally, you'll see that with degenerative arthritis as well, but it'd be much more common with rheumatoid or different inflammatory arthritis. The other thing we look at is whether there's systemic or features of disease that affect all different kinds of organ systems. For instance, with degenerative arthritis, you have stiffness, you have pain, and you have some deformities because if you get enough bony changes, you won't be able to move your joints as well. With inflammatory arthritis, though, you may have fevers, you may have swollen lymph glands, you may have lung disease, you may get rashes. So it tends to be a more all-over disease, although the joints will be the prominent area that is involved. The treatment is very different between the two. So once we decide whether it's degenerative or inflammatory, we move into different kind of treatment regimens. All kinds of arthritis do better with physical therapy and with exercise programs. That's key to keeping your good range of motion and preventing further destruction of the joints. With degenerative arthritis, we have no drug that will stop it or turn it off. So we just hope that the progression is slow and that the loss of function is very slow over time. We generally use analgesics such as Tylenol, and then the non-steroidal anti-inflammatory agents such as ibuprofen, Aleve, meloxicam, and many others that are there on the market now. And that's the best we have with that. We sometimes will couple that with steroid injections in the joints, although we have to be careful about that because it can actually accelerate the disease. There's also some hyaluronic acid compounds that are commonly called rooster comb products that are sometimes used in large joints to help treat osteoarthritis. Their efficacy is somewhat questionable, but some people will get good responses for that. Exercise is key in degenerative arthritis because the stronger you make your muscles, the less force there will be going through your joints, and hence the less damage you will have in your joints. With rheumatoid disease, we have a whole different group of medications that we use. Again, we will also use the non-steroidal agents. Tylenol is less effective because it is inflammatory, and there is no anti-inflammatory component in Tylenol. We then move on to perhaps the most common one used, which is methotrexate. Methotrexate is a drug that was initially used to treat cancers and then was used to treat psoriasis and psoriatic arthritis, and now it's probably the gold standard for treating rheumatoid disease. If methotrexate is ineffective, we have leflunomide. We also have hydroxychloroquine and sulfasalazine, which are all oral products that are called disease-modifying agents that we can use to actually try and turn down the inflammatory component and the inflammatory part of the disease. If we do that, we can prevent further joint damage and prevent deformities and disability later in life. The newest agents we have are considered biologic agents. That is, they're usually antibodies that are made that we use. These have been advertised a lot on television and are now being increasingly used because of their great efficacy. They also have significant toxicities that need to be considered when we're using them. Enbrel, Humira, Remicade, Cimzia, Simponi are all ones in one category that are used. There are other ones such as Cosentyx and Taltz and Orencia and Actemra that are also used too. So we have various mechanisms of actions and a lot of different drugs we can use. The newest class of medications we have are small molecules that are now in the Janus kinase inhibitors, which will mean nothing to people, but they turn off the production of chemicals that cause inflammation. And there are now 3 products in that group that we can choose from to use as well. The nice thing about them is that they're oral agents. What we use depends on your disease activity, also depends on what your insurance company will cover, as these are really quite expensive medications. And again, they have significant toxicity, so we use them very carefully. The nice thing to know is that these drugs with rheumatoid disease will actually decrease the activity, prolong your life, and reduce the cardiovascular risks that can be seen with rheumatoid arthritis. So in summary, there's 2 major kinds of arthritis, degenerative and inflammatory, of which osteoarthritis and rheumatoid arthritis are the prime examples. The diagnosis of those are made both by the symptoms and the examination of the patient, and the treatment regimens are quite different, but tend to be very effective. But the best thing to do is to keep moving.